After these beautiful and rich presentations of physiological data, I feel like in a fausse de loop. It's difficult for me just to counterbalance certain substantial physiological statements. Well, I would like just to start with the ERS practice guidelines, where I think asking the PICO question that addresses the major problem concerning the use of knee de novo RDS, there is indeed in the recommendation, which is a non-recommendation, some important considerations. There is a low certainty of evidence. There is not enough evidence to recommend its use. However, a trial on knee may be offered to patients with hypoxemic respiratory failure, community-acquired pneumonia, early, which means mild, at least moderate RDS, in experienced team. And a careful selection, again, are close to monitoring the ICU, reassessing early and intubate promptly if they do not improve. So I could just stop my presentation here, because the essence is contained in this slide. But what is against? I will take also the advantage just to repeat or just shorten the presentation for all the things that Dr. Chateau has shown at the beginning. The high inflation pressure caused barotrauma, the overdistension volutrauma, the repetitive opening and closing the alveoli, the atelic trauma, and indeed also the biotrauma, that is the other face of the coin that then may contribute to or perpetuate the damage and develop the multiple organ failures. What problems we may have in mild moderate RDS, that when we have these patients on spontaneous ventilatory modes, there is a deep inspiratory swing, high tidal volume, high transpulmonary pressures. And we know that at least looking at the driving pressure of the patients that are mechanically ventilated and intubated, as soon as you have overdistension and then you have an increase of the strain and the stress, you may get an increased mortality. We know that the mechanism of VILI is generated by the transpulmonary pressure, which is the airway pressure minus the pleural pressure, whose surrogate is the esophageal pressure. And under mechanical ventilation, you may find such a situation. And when the patient starts spontaneously breathing, the deepness of the inspiration and the negativity of the pleural pressure generates another higher transmural pressure. And this could be the damage. But my question is, if I apply the pressure support, and this is sufficient to generate then 10 centimeters of water, and then I reduce the inspiratory swing, are we still in a range of potential damage? The real matter is that, unfortunately, we do not have enough data, physiologically speaking, in spontaneously breathing patients under these conditions. And this is something that a gap that we should compensate. However, we know that despite the fact that as soon as we have identical conditions of flow and volume and similar transpulmonary pressure, what counts the most is again the high tidal volume generated by the fact that the patient in spontaneous breathing breathes deeply. However, this is the only existing evidence in patients coming from the study of Leher, where if you look at the effects generated by the pressure support and PIP, you may see that the esophageal pressure that has indeed at the very beginning a deep swing, it reduces a lot, and consequently also the transmural pressure that were substantially higher at the beginning were reduced. But looking at the literature, I have seen something interesting that generated my interest, and I want to share with you because it induces us some questions. What happens to the athletes? As soon as you look at the endurance of trained men and they are instrumented, look at the tidal volume that they develop during exercise. Men and women. Tidal volume of 3 liters. Tidal volumes of 2 liters and 3. And if you look at older studies done in 1969, where Olafsson just trying to respond to a specific phenomenon that this subject may have, and a sort of expiratory flow limitation, just instrumenting patients, noticed very interesting other things. You may see that they are capable, under exercise, to generate a number of different pressures and a number, transpulmonary pressure, and a number of volumes that exceeds by 4 liters, 2 liters, the vital capacity. It doesn't work. Okay. Yeah. And indeed, if you look again to the swing of the transpulmonary pressure with the vital capacity that for several liters above the total lung capacity, look at these slides, -40 up to 80, but none of these subjects generated any lung injury. I do not know why. You may say they were normal subjects, they were healthy, and for these reasons there were no conditions generating the damage. But experimentally, these were conditions that in animals generated the damage. Why this didn't happen, I don't know. However, we have the new definition. There is a room for the non-invasive ventilation in the milder form of ARDS. And if we look at the effects, we can see that in these patients, there is a risk. There is the risk of a higher mortality when they fail. And at times, what Antonio said before, if I postpone a necessary intubation, this may be an even higher risk for mortality. And this is something that may happen in the novo. However, we know that since years that when you apply the non-invasive ventilation, it works. You can not even distinguish into the first hours which are the patients under fully mechanical ventilated intubated and those who are receiving non-invasive ventilation. And the number of complications was less. When it works, the mortality rate is largely reduced and contained in a very low proportion. One of the objections made looking at the mortality rate and the lung-safe analysis was that the mortality rate for those who failed was very high. But indeed, like in all studies that we do, like in the randomized study, we have to consider the total mortality of the entire group. And when you do that, you can see that the real mortality of the entire group receiving non-invasive ventilation was 26.9. That was exactly identical to the one of those who received invasive ventilation since the very beginning. So, non-invasive ventilation, in my opinion, can be beneficial, but require careful clinical judgment to optimize the treatment, mitigate the lung injury, and improve the success rate. And the early detection treatment failure and the prompt intubation are the key issue. And Chartreux has already shown this data that suggests us that one of the major parameters to look at is the tidal volume. And when the tidal volume is generated may be quite high, this can be a good predictor of the failure. And this could be another indicator that we have to look at in order to promptly intubate these patients. In the multi-center trial that we conducted together with the Spanish colleague, we identified that those patients who were unable to improve after 1 hour of application, I'm speaking of after 1 hour, no more than that, so do not insist. They were those who were more prone to fail. Then, in this case, you have to promptly intubate them. So this is the issue maybe, the timing and the moment when we have to start with the invasive ventilation. And we know from the same survive that those who had ARDS, at that time there was no major difference for those who had a severe one and those who had a mild one, and indeed the categories of patients more prone to fail. The Chinese colleagues tried to make a combination of the heart rate, acidosis, consciousness, oxygenation, and respiratory rate in order to predict the failure of non-invasive ventilation. And they put a sort of threshold above which the probability of failure was quite high. And indeed, the higher score that they have elaborated was predictive for the failure. it was alluded to the use of different interfaces, and this is not here simply for quoting what we have done, but just to remind an important issue, that probably the tolerance that Antonio Pesenti alluded to may play a role, but not only that, because if you look at the study that was done in Chicago, they had an interesting results, at least even though the number of patients was limited and the way in which they have used the pressure support may be somehow questionable. Nonetheless, there was an improvement of survival. Why it was so? I think that possible interpretation is the higher PEEP that you can apply with this device. Indeed, we know that the recruitability of the lung is not always the same and may be different depending upon the different region. And when we do have a device where you can use a higher level of PEEP, probably this may in part help to solve the situation. So I end up in the same way I started. Again, we do not have such a huge evidence on the possibility of using this technique also in ARDS patients, but nonetheless a short trial, I repeat several times, may be attempted, carefully checking the patients and monitoring all the different variables into a protected environment with an experienced team. Then, said that, if I have a severe ARDS, no question, go away, intubate him or her, and give protective ventilation with all the carefulness that they deserve for being treated adequately.